we have a guest today, Dr. Michael McKenzie, and he's going to talk to us about assistance with medical assistance in dying. And actually, Dr. McKenzie, you're muted right at the moment, but I was going to ask you if you would like to share with us your background.
Happy to do that. Can everyone hear me okay? Okay, so I'm a radiation oncologist at the Vancouver Centre. I've met a few of you, and I presented to this group a number of times before. Usually I've given talks about, the specifics of treating prostate cancer, but a couple of times I've spoken to some other topics. And the reason I can speak to those is one of my major sort of teaching and research interests is actually supportive cancer care and various elements of that. So that's kind of taken me to some involvement in this whole area of medical assistance in dying. And that's sort of a 30-year career that's led me to that. And so, I bring to that lots of different thoughts specific to cancer care in general, but also the bulk of my work is in prostate cancer. So a lot of the patients I'm talking to about this and other related topics have prostate cancer. So, and so I'll be interested in your comments. So as I speak to this, I'll pace it. But the hope I have is that somebody's watching the chat for me. I don't know who the friendly person will be to do that, because I can stop and address any pressing questions or concerns that people come up with as we go, because this, I'm going to say, is a little bit of an emotionally charged topic for people. And sometimes if questions come up, it's good to sort of, address them when they do, because it usually means that people kind of are able to listen to the talk a little bit more easily. So can I ask somebody to just keep an eye on the chat for me? Yep. Len, you're going to do.
I'll try that. I'll try to do that, Michael.
And Len, you and I know each other well, so I'm sure you're comfortable interrupting me, aren't you?
Absolutely. Yes. Not many people know that I've known you for more than 20 years.
Yeah. Well, I think it's pushing 25 to 30. I have a feeling. How long have you been with the group, Len?
Since 1995.
Okay, so I've known you since then, basically. So, yeah. Anyway, and listen, thank you, and thanks so many of you for everything you do in this group. I always forget to say that when I come and speak to you. We so appreciate the support you give our patients, and keep up the great work, and continue to let us know how we can support you. So without further ado, I'm happy to begin the talk. Let me just, is somebody going to enable share screen?
Yeah. You are, I think.
Am I? Okay, let me see if I can do something with that. Hang on. Here we go. Let's see how that works. All right. Can you see? You can see that? Now I'm going to do.
Got it.
Okay, there goes the talk. There we go. Okay, so this is a topic at hand. Now, there's sort of nuts and bolts of kind of how the system works, and I certainly will speak to that. But there's, the actual clinical part of it. I mean, we're talking real patients, real families. And, so I'll touch on sort of all the sort of general care aspects that come up in these conversations. So quickly, I'll just say that I don't have any relevant conflicts of interest to disclose. So I'll go to the next slide. So here's what I hope to do today. So, basically, medical assistance in dying went into law in Canada in June of 2017. So we've now got, 4.5 years of experience with it. And I think it's worth reflecting on that experience as we think about where, this fits in care today. Now, of course, some of you may know that the original bill that was put into law in June 2016 was updated in March of last year. So I'll talk about those revisions. Those revisions open up a whole other conversation. It's almost another talk unto itself, because there's a lot of subtleties in terms of, how MAID has been opened up to additional groups of patients. What I wanted to talk a little bit about, just so there's takeaways for you, are the processes that are followed when somebody expresses some interest in medical assistance in dying, just to have a bit of a sense of how it goes. And hopefully we'll give you some confidence that, if people do want to make use of the system, it actually is there. I'm going to say that the reason that question comes up is because, well, healthcare doesn't always work efficiently. And people are sometimes a little bit doubtful that the system will be there if they need it. But I'll tell you how it works. Now, I wanted to close with some general concepts that relate to it. So I would say that talking about medical assistance in dying is nearly always in context of broader discussions regarding preferences for care. So I'm going to talk about concepts of advanced care planning, advanced directives, and what we mean by the term goal concordant care. But without further ado, so you can actually find this report online. I'm sorry, I forgot to put the link on the slide here. So these are images that come from the second annual report summarizing the national experience in Canada with medical assistance in dying. Now, we do keep British Columbia statistics, and I do sit on the provincial committee that looks at those data, but unfortunately, I'm not able to share those with you. Ministry would yell at me. But I am able to, because this is public, the Canadian data, and I think this is instructive. So this is a table that shows the use or the application of MAID in different provinces, jurisdictions, territories across Canada over time. And what emerges here is true in every province, but certainly in BC, the use of MAID has increased over time, which I guess makes some sense because, the system was just sort of getting going. People were becoming a little bit more familiar with it. One thing I will say that's interesting about it, though, is and I can say this much in British Columbia, how often it's used is highly variable in different parts of the province. And we can kind of come back to why that might be in a minute. But I mean, in short, I'll say we don't really know, and it does bear some further study. And we're talking about, really putting a fire under some research ideas to really take a look at that. One of the key things for this group is that across Canada, almost 70% of the cases in which MAID was delivered came with cancer diagnoses. It's a little bit less in British Columbia. It's, I think, about 60%, maybe a little more. And in total, it's across Canada, 6.6% of the cases had prostate cancer. So I thought that was interesting. And this again shows some variability in the rates at which MAID is applied. Now this time it's by province. So on the left you've got the furthest east, which is Newfoundland. On the right you've got British Columbia, and you'll see British Columbia. There's a higher percentage of total deaths were the result of medical assistance in dying provision. So it's interesting. And within the provinces, I say there's some variation by geography as well. Is that cultural? What is that? We're not sure. And this is showing the same thing I said before, but at least it gives you a sense of what some of the other diagnoses have been across the country, people with congestive heart failure and emphysema and things like that. So there's a smattering of other diagnoses as well, but mostly cancer in this report. Now, one thing that's a little bit interesting for people to see is this slide. So, if I talk to patients, families, the general public, they often think that medical assistance in dying is most often used because people are having a lot of pain. And, that can be an issue, but this slide doesn't fully address this. So basically, it's more concern about pain if, in fact, this occurs. But by far and away, the more common reasons people will ask about MAID are more to do with meaning of life, not wanting to be a burden to people, not being able to do the things they normally love to do. It's more those sorts of things. Now that comes up when I talk to my colleagues because some of them will say, well, we don't need MAID because we can control pain. Well, I don't have a tablet to restore meaning in life if somebody's not very well. I don't have a tablet that eases burden concerns. So this is really why MAID has been an option that many of our patients have chosen. Are concerns about these things, not so much the fact that they're having a lot of uncontrolled symptoms. And it is true to say that we are a lot better at controlling symptoms than we used to be. Now, the other thing I'll say about this slide, and it's not on the slide itself, but there are kind of two scenarios I'll tell you I run across in practice. So one of them is, well, somebody is feeling not very well. and life is intolerable to them right now in this moment. The other scenario, though, is they know what they have. They have an idea what the future looks like, and they don't like the look of that future. And they're talking about MAID because of concerns about what that might be in the future. And I'm going to say that is more common, right? And I'm finding that, I might think to myself, well, the person who's thinking that is going to be the person who has the largest, most worrisome cancer. In fact, I have patients coming in with low-risk prostate cancer who are worried about that. And so I kind of listen for things people may say that lead me to think that they're worried about it. Because it's a conversation that's worth having, even though, as this group knows, people with low-risk prostate cancer are likely to do well for many, many years. But that doesn't mean that they know that when they're coming to see me the first time. And it does mean they're not worried about, the fact that cancer might metastasize and cause all sorts of problems down the line. So, it just the extent of cancer does not necessarily drive whether people are wanting to ask about this or not. So another sort of thing that comes up is people will often say, well, if you provide palliative care services to them or connect them with those services, they're not going to want medical assistance in dying. Well, it turns out in the national experience that over 80% of people had been connected to palliative care services, over 80% of the people who actually received MAID. So that's one thing that I've got on this slide. So simply providing palliative care service does not mean somebody's not going to opt for MAID. And if people are in the palliative care system, they can access MAID. So they're not either or, and that's important. The other thing that's interesting here for many people is that a lot of times MAID is provided at home as opposed to hospital. And so I just want to stress that is possible if people want that. You do not have to be admitted to a hospital to have this. And the system does respond to people's wishes in that regard. And people can have it in care facilities as well. So these are the data from this annual federal report. So what do we mean by the term medical assistance in dying? So it really refers, this is the law. This is from Bill C-14, and you can read that. And basically it means that a medical practitioner is delivering the substance that will end their life. Now, the other thing that's not on this slide, whoops, I'm sorry about that. I'm not trying to get that back, but basically the law leaves the possibility of either giving oral medications or IV. The vast majority of the time across Canada, and it's true in British Columbia as well, provisions are done IV. It just turns out that mostly that's what patients prefer because it's a little bit more reliable but having oral medication instead is certainly possible. So this is an infographic that the federal government put out in March, and it's a little bit of a busy sort of a slide in a way, but on the left, just to orient you, was the original legislation. And we'll talk about how requests for MAID are made in British Columbia. There always has been a recognized set of eligibility criteria. So the original legislation said you had to have a grievous and irremediable medical condition, can't pronounce English today, and that the natural death must be reasonably foreseeable. Now, doctors found this challenging because breaking those terms down, what they actually mean in practice, comes with some challenge. But, sort of in a general sense, with the help of the college and other people, we've kind of come to some sense of what that meant. And there were safeguards. And it's, just before MAID was to be administered, there had to be final verbal consent. And the law read that if the person was not able to give that consent, then the practitioner could not deliver the MAID. So the new legislation, or the revision to the existing ones, changed that up a little bit. So first of all, it added a second track, as we call it, or track 2. So there's still the group of people that were addressed by the original legislation 2016, but now the second track is for eligible people whose death is not reasonably foreseeable. And, there's a whole discussion of what that actually means. And, we can kind of go through that in the question time if you like. now that in that track, then there's some variation. So you have to have a 90-day waiting period, and there's different things about it, and there's various exceptions and things like that. Most of our cancer work, we expect, is going to be addressed by the existing legislation, so what we now call Track 1, except that even in Track 1, there's now some provision for waiving that last-minute final consent under certain circumstances. So it means that if people aren't able to give that consent at the end, provided certain things have been put in place, that's okay. And it all has to be documented and everything else. So even for Track 1, there are some differences that mean if somebody's, not able to consent verbally, that we can still proceed if everything's been looked after properly. So that's kind of the difference. And we can talk a little bit about the details about that if people have questions. And this is just, I've just got a little bit easier to read version of the same thing. There's quite a nice document available on the Ontario Ministry of Health website that provides some details, which I can let people know about if people would like to know. Now, basically in Alberta, oddly enough, that they did a lot of the foundational work for the rest of us in Alberta. And this is a graphic from their foundational work even before the C-14 became law. And, there's the pre-contemplative phase where people are, let's say, for example, somebody's just learned that they have cancer and they're really considering their options. It sort of dawns on them that maybe this might be something they'd consider, but it's kind of free-floating, not terribly well-formed thoughts yet. But, depending on how things go, it may be a little bit more concrete. They get into more actively contemplating it. And so then they'll kind of move to the right and they'll decide, well, I really do want to pursue this. And then there's action that needs to be taken. And I'll take you through that. Now, one of the things that we haven't done quite so well, and we can speak about this if you like, but there's a whole process of looking after the family with this, particularly after the person has died. And they have thought about that a little bit in Alberta. We have too, but I must say we need to do a lot more on that end of it than the far right of that screen. Now, so if somebody is, thinking about MAID, I'll talk a little bit about the conversations one should have with your healthcare team, but let me start with the resources that are available to you online, for example, and by phone and by email. So as you may know, there are 6 health authorities in the province. There are 5 regional ones, and there's the Provincial Health Services Authority, and all of them have a website like this. So I've got the Vancouver Coastal one up here for no particular reason. And this is a resource that's helpful both to healthcare professionals at large, for people who are actually involved in the whole medical assistance in dying system, but also to patients and families. And I'll take you through kind of the resources that are available there for you. So, for example, and this will be, since this is being recorded, you'll have access to this. So I've got the website, the link to that for the Vancouver Coastal Health Authority there for you, because I'm assuming most people on the line would live in, the catchment served by Vancouver Coastal or Fraser. And so, for example, here's the email you would reach out to if you have questions or concerns, and this phone number. And it actually works. I know the people who staff it, and they do a really good job. And the thing is, they don't confine how they help you just to MAID. They often will help connect you with other services you might need if in the conversation you're having with them, it's obvious that some other help might be useful, and they'll connect you to other folks if needed. And so they have, and I'll put later on, I'll put the link to this in the chat. They have a really good brochure. They've really put a lot of thought into it, and there's been patient input and family input and everything else. This is quite good. Now, some of you may live in Fraser. The catchment area is served by Fraser Health Authority, and so they have similar resources. This is the link to the website for them. This is the phone number, answered very ably by either my friend Tammy Dyson or somebody who works with her, somebody who used to work with us at BC Cancer, Sue Bartnick. They're very good. Same idea. There's the email you'd contact, and it actually does work. They're very, very helpful. And this is what their information looks like. We've gotten really good feedback from patients on it, so it's good. So to take you through there's a whole bunch of paperwork. So this is not a loosey-goosey process. So from your perspective, the first thing that would need to be completed before any of the rest of it can happen is something called the record of patient request. Now, the slightly tricky thing about that, I mean, the form's okay for the patient to fill out, but it does need to be witnessed by somebody who's not your family, who's not in the will, who isn't involved with your healthcare. And that's a little tricky if you think about it. Who you get in as a witness to sign this thing that doesn't in one of those categories. And basically the MAID office, when you phone them, can help you get your mitts on this form, but also help you connect with a witness, right? If you can't come up with somebody in this category on your own. Sometimes that takes some time, but the Dying with Dignity people are available to, the volunteers from that organization are available to help, but sometimes they can't come absolutely right away. So that's, but that's the one slight hiccup if sometimes there's a little bit of a delay in getting connected with a witness if you can't contact one yourself. So then what happens once that's in, there is what's called a first assessment done. And I'm going to say for cancer patients, the way the health authorities prefer that this is done is to have the oncologist that knows the patient do that, because we know you already, right? And you know us, and it just makes the whole process a lot easier and less stressful. It gets trickier, of course, if you don't know an oncologist already, but most people in your community will know an oncologist. And now the one slightly challenging thing is if for some reason the oncologist doesn't want to do that. Now that happens more or less commonly depending on what part of the province you're talking about. In BC Cancer Abbotsford and BC Cancer Surrey, what I'm hearing is for whatever reason, I don't know exactly why, the oncologists are a little less likely to be willing to do that than oncologists in Vancouver are, for example. But basically what should happen is the office that you phone and the health authority should help you problem solve that. And hopefully somebody at BC Cancer will help them problem solve that. But in any case, basically it's a fairly straightforward thing. It can be done online or on the phone if we know you already. That's the other thing that makes it so easy. So once that assessment is done, provided there's no concerns at all, the next step would be another assessment that would be done by whoever it is that would probably be the one who actually would give the medication. That they don't give the medication at the time of the assessment, just to be clear, but there are some other sort of conversations they have about logistics and stuff like that. If needed, either the first assessor or the second assessor can arrange for determination of whether somebody's competent to make their own medical decisions, right? So let's say somebody's got memory problems and stuff and there's concern they have dementia or something like that. Then, if needed, we can indicate that a consultation with a psychiatrist or something is required. And then there's other forms for when the actual medication is given, so that they're done in the right way and everything. So the system is very robust, and I've been involved in development of it, so I can say that. And I mention that because sometimes families are worried, and it's, in my case, because most of my work is prostate cancer, it's usually the guy bringing it up. And the family may not be 100% comfortable with it, and they're worried that something will go sideways and everything else. But at least, I can say to them that the system does work, and it's provides the care that's needed. This to just give you an idea is the patient request record I mentioned to you before. It's not 58 pages. It's fairly straightforward. And basically the only tricky bit is having the right sort of witness, but we can help with that. Now, one of the things, so when I talked about physicians not wanting to be assessors, for example, or being involved in discussions about medical assistance in dying, I mean, one of the reasons can be conscientious objection. I'll talk about that in a minute. But this is a study that was done in Oregon. And as you may know, in North America, Oregon is the jurisdiction that's had this provision around for the longest. And they did a qualitative study talking to physicians who sort of had some, connection with conversations about medical assistance in dying. And, physicians themselves, may be uncomfortable. They feel unprepared to have the discussions or apprehensive about it. Obviously, there's symptoms that patients may have that they may not feel capable of adequately managing those symptoms and the suffering that goes with them. At the same time, they don't want to abandon people. They're worried about having to, engage in, shared decision making with patients and families. You guys know better than I am probably that, some physicians are fairly paternalistic to this very day. But there's also concerns about sharing control with other people and involved potentially with administering medical assistance in dying. And the other thing that's pretty clear is, physicians themselves often will admit that they don't fully understand what patients want. And you know what? Other studies show that they're right. They don't. So, if it does come up for any of you, and I hope it doesn't, but if it does, just bear in mind that there's a human being on the other side of the desk, so to speak, and these are the sorts of things that they may be thinking about. You may not necessarily get back from them what you're kind of hoping for. Let's put it that way. That doesn't mean that's right, but it's the reality of it. So conscientious objection. So, the law is such that you can't force an individual healthcare professional or a facility to be involved in MAID in any way or form. So for instance, there are, as I say, some of my colleagues who will not do a first assessment because they object to it on religious grounds or whatever. Faith-based acute and long-term care facilities, for instance, you cannot have a MAID provision at St. Paul's Hospital or Mount St. Joseph, for example. So if somebody's an inpatient there at the moment, they have to be moved. And there's other, faith-based facilities across the province that are in the same bracket. And the ministry is not thrilled about that, but there isn't anything in the law that, can make them change that really, or enable them to change that. Assessments can be done at St. Paul's, for example. But even that, it can be a little tricky. So, but let's just say the Ministry of Health is working on that, but I don't think that's going to change anytime soon. So just to pivot a little bit, so I see medical assistance in dying conversations as a really specific form of advanced care planning. And I think that talking about medical assistance in dying should be embedded in a broader advanced care planning discussion. So we're going to talk about what I kind of mean by that. So a couple of terms. So the first one is advanced directive, and that is really completing a couple of things. So you'll see this is the cover of the paper version of what's called My Voice. It's the Ministry of Health Advanced Care Planning Guide. It has information that explains, but it also has the forms that you fill out. Now, I'm going to say we've been at the ministry to improve this for some time, because if anyone's looked at this, you'll see it's a bit, well, it's not entirely user-friendly, shall we say. But I mean, the necessary paperwork is in there. The fundamental of it is what's called a representation agreement. There's two versions of it. So that one is really about assigning who's going to speak for you if you can't speak for yourself surrounding healthcare matters. So it's sort of the equivalent of a power of attorney, which is for financial and legal matters, but it's for healthcare matters. Now, the law that was put in place in 2011, there's a default if you don't have one of these things, and it's usually your spouse, for example. Or if you're a widower, then it will be one of your kids. Now, here's where having a temporary substitute decision maker established, let's say you are a widower and you've got 6 kids. Let's say there's one or more of your kids that you think may not really be very good at this or might not want to do it. It's good to have one of these representation agreements, because you can say, I want Bobby Joe to do it. And then the other thing is the other members of the family understand that. And ideally, you discuss it with them so that Bobby Joe doesn't get inordinate grief after you die. And there's other examples of where having this set would be a good idea. For example, let's say you don't have any family. If you don't have one of these things, I heard about a case like this recently. It gets really tricky, because who do people talk to if the patient can't speak for himself anymore? Now, in this paperwork, you can put down other preferences for care, and we'll talk about what some of those can be. We are actually trying to encourage everyone over 18 to put this sort of paperwork in place. Now, how likely is it that a 19-year-old is going to do it? Not very, but it's possible, unfortunately, that a 19-year-old could wind up having a head injury and benefit from one of these things. But in reality, it's mostly older adults, and we're kind of focusing, for starters, on adults who have, serious illnesses. But we've got a long way to go even in that population. And maybe in the... Sure.
John, we just have a question. And the question is, can I presume that does not have to be done by the assessment does not have to be done by an oncologist?
No, it doesn't. It could be done by the family doctor.
Okay.
Yeah, that's right. Yeah.
So sorry for that interruption.
No, that's okay. You probably were trying to stop a running train there for a while there, Len. Sorry. Yeah, and just maybe when we get back to the end of the talk, I'll be interested in how many people in this group have actually completed one of these. But on the bottom, I've got the website where you can access all this stuff quite easily. And the one thing I would say, if you do this, and I do encourage you to consider that, as I say, do make sure you discuss it with your family and other loved ones. Definitely involve your family doctor in the conversation. Tricky bit is, do you have a family doctor these days? But hopefully you do. And the other thing is, once you've completed it, make sure you share the paperwork with your family doctor, right? And ideally with us as well, because paperwork like this does not do any good if it's sitting in a drawer in your kitchen. So that's an advanced directive, and that's a sort of a static thing. It's a piece of paper, and it's still worth it. But oh, and here's some other bits that can go with it. So on the right of this screen is something called the Provincial No Cardiopulmonary Resuscitation Form. And so basically the idea there is, if you decided you did not want somebody to restart your heart if it stops, you don't want to go to the ICU and have a machine breathe for you and all that sort of thing, this is the form that you would sign. And, oftentimes if somebody has serious illness and they're at home, the home care nurse that might be visiting them will ask about this. And, if it's signed, it's usually put into place so that if the ambulance comes, that they know that this has been signed. That's how it works in Vancouver Coastal. In Fraser Health, they'll use something different, which are called MOST orders, MOST standing for Medical Order for Scope of Treatment. And it applies in hospitals in Fraser Health, but you also, the same form works at home. It's sort of a variant of what you see on the right of the screen, except it comes with a little bit more detail in terms of the levels of care you might want. So that's, again, paper. Now, the problem with paper is it's kind of fixed at the time you fill it out. And, things can change. Now, the trick is, if they do change, it's worth updating the paperwork sometimes. So it's worth keeping in mind you've got these things, and, keeping in mind you may want to update them depending if something new is going on. Now, more relevant, I think, is the concept of goal concordant care. Now, that's medical gobbledygook, really, but what that really means is, and to you guys, it'll be like, of course, right? But it's not how healthcare works. So the concept is that people get the care that they want, that supports them to live their life they want to live, the way they want to live it, and delivered in a way that works for them. This is how it should be, isn't it? And what that looks like may vary depending on what's going on with their illness, and that can change over time. And so basically, it's a much broader kind of process, where you talk to the patient and family, you figure out what's important to them, practically what their situation is, all of those sorts of things. And, it's a conversation that continues the whole time that a healthcare provider is working with that patient and family. Now, is that how that goes every single time in the healthcare system? No, but again, that's kind of what we're building toward provincially. And I'm working with lots of different partners. I will call out and credit the BC Centre for Palliative Care that is really working a lot on this with health authorities, with doctors, with nurses, to get people to the stage where this is the care that we're delivering to patients and families. And also we've got a lot of engagement with patients and families to try and make this happen. So you know, I mean, just to give you an idea of the sorts of goals for care I'm talking about, and they'll be familiar to you, that I'll be thinking about. So sometimes it'll emerge, you know, that people, whatever you do, keep me out of the hospital, right? So there's a lot of thoughts that go through my mind as an oncologist as to how I would talk to them about that, what services I might want to mention to them, all that kind of stuff, referrals I might want to make. This one, I do not want to be a burden on my family, is a big one, because it's, at least for today, because it's often one of the fundamental reasons, like I said before, that people are thinking about medical assistance in dying. There's a whole conversation about that that has to be had, about the levels of care that are available at home and various things like that. But you know, even when I get through that, that's still a concern people may have. So if I hear somebody say something like that, I will actually actively bring up the question of MAID. So they may not have said anything about it, but I'll say something like, well, you know, often when people tell me that they don't want to be burdened on their family, they may be wondering about medical assistance in dying. How about you? And I'm going to say about 2/3 of the time, people say, well, actually, funnily, you mentioned it. Yes, I have. And it's a really worthwhile conversation to have, because they're often kind of really anxious about it. And sometimes that initial conversation is all the conversation they ever want to have about it, and that ramps the anxiety down, then they move on. But sometimes there are more, you know, practical things that come out of it that they do want to continue to explore. But non-medical things, practical things people want to do. This is one I heard: I want to be well enough and available to attend my granddaughter's graduation in Ottawa, right? So what might I do with that? Well, I might say, oh my, I don't think you're ever going to be well enough to go, but I'm not going to say that. What I'm thinking is, well, okay, what's the nearest to that I can get, right? And talk to them about how to problem solve that. Maybe they'll live stream it these days. Maybe your granddaughter can reprise her graduation in your backyard after she gets back, put on her cap. And I mean, there's all kinds of things. So to try and get it to the nearest that we can. But sometimes there are things about that that will mean that I'll structure their care differently so that they can go. So for example, I might not recommend to them anti-cancer treatment that's going to just, it's time consuming so they can't go, or it'll just make them feel unwell so they can't go. So I might make different decisions about the cancer treatment I recommend. Another one you'll hear is something I had somebody tell me this recently: brand new grandchild, age 9 months or something. And what he told me was, I want to live as long as possible to see my grandson start kindergarten. That's literally what he told me. Tears in his eyes, the whole thing. And so that was his priority at that time. And so he wanted to hear all about survival benefit with all the treatments that we had. Now, later on, as it turned out, his thoughts about that changed a little bit. It became more obvious to him that, you know, maybe that wasn't going to work. But he shifted. He said, well, you know, my grandson is in preschool. I'd like to be able to get to these little preschool events, the Christmas recitals and stuff. So his expectations kind of shifted a little bit over time. And, you know, the trick is we had to be nimble to kind of respond to the changes in his thinking.